and probably your professors, all of us in this room have heard a lot of excuses of why you may fail. One that I was told very young in life that was probably one of the most hurtful things that I've ever been told is that you can have a family or you can have a professional career, but not both. And I think that's absolutely wrong. I've raised two wonderful kids doing this profession. Now again, something discouraging. My son just finished, actually 2 years ago, he graduated with a bachelor's of science in sociology. And he struggled to find a job that made above minimum wage. So he's got a 4-year degree, and he can't make money. Yet there's lots of 2-year degree respiratory therapists that come out and have a job that makes $10, $15 more an hour than he does. And so when I hear this excuse, I'm like, whew, you really don't know what the market's like. And there are lots of folks that are struggling with severe loans, and bachelor's degrees that cannot get a job. And so you will make a living in this profession, that is for sure. And then some people are afraid to be vulnerable, and I mentioned this earlier, and that's something that I think is something that held me back quite a bit, especially when I was younger, is I was scared to let someone know my weaknesses. And you truly can't grow as a professional if you don't share your weaknesses. Like, hey, I don't understand that. So I didn't understand 80% of the questions last night at the Sputum Bowl. But I was looking up some of them, Googling, going, I don't know. I think my answer's right. And I think you guys probably were doing the same thing, but you have to be vulnerable, and you have to say, hey, I don't know, but I'll find the answer out for you. And I think that's where we're teaching people nowadays, is that you don't have to memorize things. So the Sputum Bowl kind of gears you towards memorization, and that's not really where I think our profession needs to go. Our profession needs to go to critical thinking. In other words, you don't have to know the answer, but you have to know where to get the answer, if that makes sense. And so being vulnerable with people, particularly your mentors, going and reaching out and finding a mentor. Sometimes mentors are not going to walk up to you and say, hey, I see something in you and I would like to mentor you. In fact, most of your mentors, if you ask them, they will say no, because they're not sure they can do it a lot of times. But seek them out. Seek out the characteristics that they have that you want to mimic, and reach out to them and be vulnerable and say, hey, I need a good mentor in my life. Would you be willing to be that mentor? That's being vulnerable, and that's putting yourself out there a little bit, and it's uncomfortable for you and them a lot of times. But doing that, I think, is something that's important, because it also gives them some professional responsibility for your future as well. And they can help teach you some of the mistakes, or prevent you from doing some of the mistakes that they may have made in the future. And then the last one is the word unless. I can't stand this word, because everyone will say, I'll be a professional unless I get pregnant, unless I can't pass this class, unless I can't pass this registry exam, unless often. And so that's a word that I would love to delete out of our vocabulary, is that you can do all these things. It may take work, may take multiple attempts at a certain exam, those types of things, but you can do it. All right, so now I'm going to get on to my objectives of what I want to talk to you guys about after we've kind of covered the professionalism aspect of things. And so I'll review with you guys the ARC mission and vision statement and how impact goals and movement of our profession is going. And I'll go over some of my presidential goals, and then kind of guide a discussion around why I picked those goals. And then hopefully I'll bring some information up to your level as far as like state and local about the impact that it may actually exist. So one of the things that I want to first start off with is that we have a bright future. And the reason that we have a bright future is not necessarily because of the people in this room, including myself, but it's the people before us. I often say that our practice where it is today is not because of us, it's because of those folks that worked really hard prior to us. Does that make sense? And so a lot of times we are planting trees, for example, in our profession in which we will never sit under the shade of. And so you have to think that forward a lot of times, is that, man, you're going to be doing things in your profession, you're going to be advocating, you're going to be fighting for things that you may never see happen in your career, but others will. Does that make sense? And because of other people that worked hard before us, hopefully we can plant those same trees that someone else will benefit from. Does that make sense? But sometimes it's really hard to look outside of us. You know, a lot of times it's hard for me to even look past 2 years ahead. I'm good at 2-year planning, man. I can knock it out. 5 years, I don't know. I don't know where I'm going to be. 10 years, whew, I don't even know if I'll be alive a lot of times. And so we have a bright future, mainly because of our wonderful past. And then I was glad to hear one of the Speed and Bold questions last night is, how old of an organization are we? Which you guys failed at, by the way. But we are turning 70 this year. And so you'll see a lot of kind of things that we've been doing to try to promote education and recognition of our 70th birthday. And so we have lots of publications that are coming out in the ARC Times. We also have a virtual museum, those types of things that are highlighting kind of our history. We have many divisions in the ARC to be proud of. And some people lump us all into a bunch of different groups. And so I want to kind of clearly go through some of these things. And so obviously the ARC is the parent company of basically the foundation. So the foundation is something that we use to give grants and those types of things. And then obviously Respiratory Care is our professional scientific journal as well. And so let's talk about what the ARC does. And so kind of our goal is to promote, advance, and advocate for the profession. And you'll keep hearing me say that over and over again. But some of the first things that we've been doing since my presidency is I really want to start partnerships and advocacy and try to knock down some of these silos of information. So we have lots of other professional organizations that do great work. But I think together we could actually do better work, if that makes any sense. And so, so we've helped with the COPD Foundation and launched a COPD readmission conference. We've partnered with the CDC for disaster response. And then I don't know if you've seen some of those gross commercials. People popping their teeth out. Oh, that one just kills me. About throat, lung cancer, those types of things. The stomas and using different techniques to clean their stoma and those types of things. We partner with the CDC to make those as impactful as possible. Because we want to obviously stop people from smoking. If they see the end result of smoking, hopefully they'll stop smoking. We've created a disease management educator program in conjunction with 7 different organizations. So again, we're stronger together than apart. We've hosted our 2nd annual Patient Advocacy Summit that just happened last year. We're partnering with the Chinese Thoracic Society to develop more respiratory care programs. And I'll talk a little bit more about international stuff later. We're focusing on more meaningful relationship with ATS, CHES, ACCP, those folks, because we often have like missions and visions. We may cater to a different professional population, such as physicians or nurses, but we certainly can work together a lot of times. And then you heard a little bit about telehealth, and I think you'll hear, so I don't want to steal the PAC's thunder this afternoon, but you'll learn some more about our political advocacy that we've been doing, particularly focusing on telehealth right now. The AARC provides wonderful education and continuing education. One of the things that I will always try to impress upon you guys is to always be a student. And one of the things that I love about where I work and in the area that I work in is we're largely teaching facilities. And one of the hospitals across town it's a little hospital called Mass General Hospital. They're actually a huge hospital and well known. And one of the things that the professors or attendings do is they wear short jackets. And how many of you guys know what the difference between a short jacket is and a long jacket among physicians? Tenure, okay. Anything else? When I was in Montana last week, they said 13 inches. I thought, that's brilliant. And so threw me totally off my game. And so short jackets are medical students. So like a jacket like this, but white, is the sign of medical student. In most places, when you've graduated or you're attending, you get a long jacket. I don't know, just to drag the ground, I don't know. But if you worked in those academic centers, you often knew the medical students from the residents because of their jackets. And so when I went to Mass General for the first time, I was like, wait a minute, I'm confused. Everybody has short jackets on. Who the hell is the attending? And one of the attending piped up and says, oh yeah, that's kind of a thing that we do here. And I'm like, well, what do you mean? And he's like, well, one of the things that we want to teach is that you should always be a medical student. And so that's why they all wear short jackets, because they always want to be a medical student, meaning they're never stopping learning. And I think that's something that we have to impress upon our folks as well, is that we should always continue to do that. And the ARC supports that. And we continue to provide thousands of educational hours, continuing education. We've also launched the ARC U, or university, in which you can take 3 different tracks, and so trying to create pathways for people to continue to educate themselves. So if you want to be a manager, there's a manager's track. If you want to be a researcher, there's a researcher's track. If you want to be an educator, there's an educator's track that you can take and get mentored by these different folks that actually sit in on those lectures, provide those lectures, but also have discussion boards and those types of things, all through just the ARC. And so we're continuing to try to push that program as much as possible. Obviously, our conventions, I think, are best in class. If you've ever been to one, it's just crazy. And so how fun it is. And we work really hard to make it that way, and to try to provide as many opportunities. It is a lot of work to put together such a large meeting, and if we couldn't do it without our volunteers that put these together and spend hours, literally hours and even days, on matching up content with what we think the members want, with the expert speakers and those types of things. And so this year it's going to be in Indianapolis. It's a gamble for us. We've never been to Indianapolis, and some of you guys are going, what's in Indianapolis? I don't know. I've never been there myself. But I will tell you that that we're experimenting, and we're experimenting because we normally go back to New Orleans this time of year. And that's a great city, and we love that city. But they've become very, very expensive. And one of the things that we know that our members want are cheaper room rates and flights. And that city could not provide that to us. And so trying to listen to our members, we said, hey, well, where else can we go? And Indianapolis did a really great sales job on us, because if you think about the number of people that can actually drive in that region, it's significant. And they have the facilities to host us. That's another thing, is that we are a very large group of folks. And so anywhere from 5,000 to 7,000 respiratory therapists show up at these things. And so not just any city can hold us, if that makes any sense. And so we have to find these places that are big, but also not too expensive. And so Indianapolis is a calculated experiment for us. And I'm proud of our board for doing that, because it takes some guts. But so far, registrations and those types of things are actually above pace for most of our meetings. And so we're excited that people are kind of taking this gamble along with us. We'll continue to try to do things like that. And oh, by the way, New Orleans has called us now. All of a sudden, they're like, you guys did call our bluff, and you're not coming this year, right? And we're like, yeah, right, we're not coming this year. And they were like, wow, that's really going to hurt on our alcohol sales. And so I'm like, yes, it will. And so they want us to come back, and so they've now changed their tune, and they've lowered their rates, and so we'll probably be going back there in, I think, 3 to 5 years. I can't remember the exact time frame, but we will be going back to New Orleans because that is a city that most of us love. When it comes to respiratory care, this is our professional journal. This journal is very busy, and these guys have you in mind. So Dr. Dean Hess, the editor-in-chief, is a respiratory therapist, and when he reviews manuscripts that are submitted, and there's over 750 that are submitted each year, he has you in mind, because that's what this journal is for. It's like, how will this change your practice? How will this help your practice? Those types of things. And so we just had our 55th journal conference that I was the chair of for pediatrics, and that's going to be published in June, where we actually brought in experts from all around to discuss a very specific topic on pediatrics. We have wonderful volunteers. A peer-reviewed journal does not run by itself. You have to have peer reviewers, and so people that take time out of their day to actually review your manuscripts, give you constructive criticisms and feedback on those things makes the papers better, and then also for submission. It has an international outreach, and so you'll notice that we publish things that have lots of physical therapists, for example, or physicians in foreign countries, because we still believe that you should know about those types of studies, even in the U.S. And so that's one of the things that we are striving to do. And it's one of the largest benefits of our patients, of our members. And so you get this journal, you get access to it, whether you get it in print or not. They also offer CEUs as well. So you read these journals, you answer questions, those types of things. You can get CEUs along with that, and so that's nice. The foundation have yet to update these numbers, but I'll have these numbers soon. But basically, they raise a significant amount of money for our profession. And again, this is your foundation, and this is the folks that we are trying to help and support. This past year, we provided 3 grants totaling $37,000, and these were postgraduate awards because, again, you'll see some of the focus that I'm trying to take us is in postgraduate education. And so trying to get people at the master's level and the terminal degree level, because as our educational programs grow, we have to grow our leaders in those arenas as well. And so we're trying to direct some of our funds to that. They support the journal conference a lot of times. We supported 3 international fellows last year, and we'll do another round this year. And then we've had our 3rd annual fundraiser that has been very, very successful. But we still need your money. So if any of you guys are independently wealthy, you can write a check to me and the foundation. Just kidding, the foundation. I won't take any of it, and go from there. So kind of in summary about being a professional, when I tell you that, it's about knowing, doing, helping, learning, I'd like to just kind of do this little schematic with you, is that, respiratory care, about knowing. In other words, you read that journal and you participate in that particular journal conference or reading, those types of things, that will help you with knowing. When you're doing, so obviously your job is certainly important, but when you're volunteering and you're serving, you're on committees, you're taking extra time out of your day to do things you're doing. And I think that brings satisfaction. Helping, the foundation again, so if you donate money, you help them with fundraisers like we have every year, just volunteering your time, you're actually helping them help others and our profession along the way. And then learning, obviously the ARC has CEUs, but you also have local and national meetings and conferences and those types of things that help you continue to learn. So now let's get to the mission and vision of the ARC, and then you'll see how over the next 2 years I plan to use this to help guide the ARC with my particular goals. And so when you think about the ARC mission, the ARC, the American Association for Respiratory Care, will continue to be the leading national and international professional association for respiratory care. And I want to pause at the national and international because obviously nationally we're pretty well known, but internationally we're not. And I think that's a vulnerability that we need to think a little bit about. I work with a lot of physicians from England who, when they come over, they don't know what a respiratory therapist is. They don't even know what our job is, like where do you fit in? And so we have to convince them often that we make a difference, we are a valuable healthcare provider. And stop touching my ventilator, by the way. And so, because they're just not used to that. There is no profession really in England, for example, or in the UK of respiratory therapists. And I'll show you that they're also one of the more efficient healthcare systems in the world. And so that ought to sink in a little bit because if they can provide just as good as results as us at a much cheaper rate, where do we fit in? And so we're working really hard. That's why the foundation is supporting fellows so they can come over and see our practice, see where we fit in, and those types of things. You know, Lisa and them are going to Ghana, and you know, Weber's got a big presence there, and which I think is great. Again, just advocating for our profession in other countries. South America, which I'm very engaged with, they have a profession of physiotherapists that train as respiratory therapists, and so, but their background is in physical therapy. So they go 4 years of physical therapy school and then another 2 years for respiratory school. And so they kick our butt when it comes to rehab. That's something that we've lost as a respiratory therapist, is that many of us have forgotten how to actually rehabilitate patients. And you see a big push in the ICU to get patients up and walking and those types of things, cycling, all this other stuff, which is just as important a lot of times for the respiratory system than physical therapy, you know, would think. And so we need to be advocating for that. And in South America, because they're so much more comfortable with physical therapy, they've been doing this for years. And hands down, a lot of times beating us, particularly with decannulation of patients who are chronically ventilated. I remember bringing a guy up from Brazil, and he pulled me aside and he said, "Brian, this is archaic, what you guys are doing." So in pediatrics, a lot of times we would not decannulate someone until they're off of all positive pressure ventilation. And he's like, "Why? Why can't you decannulate them and put them on mask ventilation and then step them down that direction? You reduce the risk of infection and all this other stuff." And I'm like, "Oh my God, you're right." But we just didn't think about it because we didn't focus on the whole patient. Does that make sense? And so he would decannulate them, put them on mask ventilation, and work them out and teach them how to struggle through this and endurance and all those other things. And so we were archaic because a lot of times we wait for them to magically heal themselves, and it just doesn't happen. They need rehab a lot of times. And so rehabilitation, that therapy part of our name, really needs to be brought back in my mind. And so, all right, off that soapbox. So the other thing is that the vision statement is the ARC will encourage to promote professional excellence, advance the science and practice of respiratory care, and advocate for patients, their families, the public, the profession, and respiratory therapists. So promote, advance, and advocate, and we'll continue to keep coming back over those as well. All right, so for the next 2 years, one of the things that I want to focus on is quality. A lot of us don't focus on quality of respiratory therapy, or we think quality of respiratory therapy is doing all your treatments within a certain time frame, or not having missed treatments. That's our quality indicator. Sadly, 80% of probably what you do has not been proven to be helpful or effective. And so if you're late on something or you miss something that should have never been done in the first place, that's not quality. And I think that's something that we've got to think through a lot of times, is that we're doing a lot of inappropriate therapy. And I really struggle with this because we have clinical practice guidelines that people don't follow. Look at the one on airway clearance, you know, and things like that. Routine airway clearance should not be done. How many of you guys do routine airway clearance? I think everybody's hand would probably go up and go, "Yeah, I do Q4 this, Q4 that, Q6 this." That's routine because it's not been proven to be helpful or effective. And yet you bill for those. And so we know that we're one of the most expensive healthcare systems around, and it's not helping patients get out of the hospital sooner. And so we need to refocus on quality and doing things that make sense. We also need to work on the quality of respiratory therapists, because I think some of this critical thinking will come with increased education. And so continue to advance educational requirements, promote access to high quality continuing education. So a lot of us practice the way that we graduated, and we don't evolve. Does that make sense? And so if I practice the way that I graduated 22 years ago, I probably wouldn't have a job, but that's one of the things that I think would be doing a disservice, and a lot of our colleagues do this. They continue to practice that same way. We need to expand efforts to obtain research funding and develop the next generation. So we need to prove that a bachelor's prepared respiratory therapist does a better job than an associate's degree, or a RRT does better than a CRT. That evidence is not there. And so we need, as the ARC, to put our money where our mouth is and actually start promoting those and studying it and studying outcomes. We need to encourage the development of programs and accreditation for the advanced practice respiratory therapists. And so this is another avenue that we are promoting as a pathway, a career pathway. I'm so tired of losing really good respiratory therapists to nurse practitioner school or PA school or medical school even, a lot of times because they want to practice at a higher autonomy level. And so we should be able to provide that in our ranks. And so we're working really, really hard on that right now as we speak. When it comes to safety, obviously we want to lead in advanced mechanical ventilation safety, and I'll share with you a little bit more details about that in a minute. But that's something that largely most departments control, is mechanical ventilation. So why not be the safety leaders in that versus just lumped into the Joint Commission is that you have to monitor alarms appropriately. Let's lead in that direction. It's life-sustaining equipment. It's serious stuff. People have died from it. We need to improve access to a respiratory therapist, the right place, the right time, and the right expert. I can't tell you how much we kind of generalize things, or we put people in areas in which they probably shouldn't be at times, and so that can be a safety issue, and so we need to think through that process. We need to maintain and expand relevant communications with alliances of key allies and organizations. So again, we're reaching out to join development of clinical practice guidelines of other physician organizations, because we can have this great clinical practice guideline that says you're not supposed to do airway clearance routinely. But if our physician colleagues don't know about it or agree with it, how effective do you think it's going to be? We're seeing the results of it today. And so I just had a conference call with the ACCP this past Monday. And again, just trying to partner with them on tracheostomy care, for example, is one that we're going to partner. Neuromuscular disease is another one. And so if we write a clinical practice guideline together and we both publish it to our both groups and support it as organizations, I think it will hopefully impact patient care a lot sooner. Does that make sense? All right, and then the fourth one is to continue to advocate for our patients, caregivers, and families. And that's a no-brainer. But sometimes I think we get in the way of ourselves and don't actually put the patient first. It's more about us. And I really think that we need to refocus a little bit on that. Now, value. Value is a big term right now, and it's hot in healthcare. And we're going to talk more and more about value. And I hope that it's going to become part of your vocabulary, because if you don't add value, you really shouldn't be there. And we probably will be eliminated if we do not add value. Consultants are doing it now. They're coming through and cutting departments in half because they're doing a value proposition. How do you value the organization? How do you value your patients and those types of things? And so we'll continue to develop and execute strategies that will increase membership as well. We're only as large as our numbers say we are. And so when I was in Washington, D.C. just a week and a half ago advocating for you, I could only say that I'm speaking on behalf of 47,000 respiratory therapists. Does anybody know how many respiratory therapists are actually in the United States? I hear 97. Nope. Much higher. 172,000 respiratory therapists. And we have 47,000 members. So it's like, ugh, it's hard, because I guarantee if I was to tell some congressman or woman that I had 172,000 respiratory therapists supporting me in my initiative, they would be like, that's a lot of votes. That's a lot of votes that could actually get me ousted if I don't do what this group wants me to do. Does that make sense? And so numbers is power, sadly. But that's what we need to do. We need to continue to advance our international respiratory care community and presence. Again, I think it's a vulnerability. When you see others that are practicing without us and doing equally as good a job, I think that puts our heads on a chopping block at times. And so we're working hard with China and those types of things, because they see the value of us and they want to develop programs. And we're working as hard as we possibly can to develop those programs. Promote activities to increase public awareness of respiratory therapists. This continues to be a struggle. If a man walks into a patient's room, they're seen as a doctor or a PA or something like that. If a woman respiratory therapist walks in a room, they're seen as a nurse or something else. And that has to change. we have to be recognized for the profession that we do. And that's something that we continue to work on and promote that awareness. I will have to say that when I was in D.C., this was the first year that I've gone to D.C. where everybody that I talked to knew what a respiratory therapist was. I can tell you in years past, it was about 50% knew what we were. Many times we were lumped into the allied health group, under that blanket. Didn't know the differences between a radiology tech and a respiratory therapist, except that we share acronyms at times, and so some of those things. But this year, I think we've made a headway, and so that was something that was kind of eye-opening to me that, hey, some of our hard work is actually paying off, is that when we're advocating and telling our Congress folks that what we do, they're actually starting to get it. Promote and advocate for appropriate patient and caregiver access to respiratory therapists. Again, we're darting after any avenue that respiratory therapists or our patients can get access to respiratory therapists, and so telehealth is a big one. Can you imagine if you could do reinforcement education across a video and get reimbursed for it? Those types of things, help with spacer instructions, or just touch base with someone who's not doing so well to see if they need to go to their doctor or do they need to go to the emergency room. Those types of things I think will be very helpful in the near future. All right, so why did I come up with safety, value, and quality? And so first, I'm a big fan of the KISS philosophy. If I can get you guys to remember 3 things when you walk out of here, I will win. I promise you. So safety, quality, and value. Historically, the ARC has kind of bombarded you with our strategic goals, our 15 strategic goals, and then we start talking about goal number 13, and you can't remember what number 1 was often. And so sometimes we've overcomplicated our message. And so I am hopeful that if you just think about quality, safety, and value, that you will be able to fit your thought into that and then make a difference for us in the future. And so let's start with safety, because I think that's something that I'm a big advocate of. And there's some eye-opening things that have occurred in the recent years. And so this was published last year, is that medical errors are the 3rd leading cause of death in the U.S. This is like saying that you work for Philip Morris. Think about it. If you work for a hospital and you're the 3rd leading cause of death, you pushed COPD down by 1. COPD used to be the 3rd leading cause of death. Now medical errors has actually pushed its way in there, and so that is crazy to me that we would sit by and just say, that's okay, and not do something about it. And I don't think our profession is immune to that. One of the reasons I want to focus on ventilator alarms, for example, is this publication that came out now 7 years ago in the Boston Globe, in that ventilator errors were linked to 119 deaths that they could actually figure out by birth or by death certificate. And so you can imagine that there are some that have death by other reasons listed, hypoxia, those types of things, but it was really a medical error that we cannot capture. And so this article goes through all the different reports, and it's 119 that they can find directly linked to ventilator errors. And if we're responsible for that care, we ought to pay attention because 1 death's too much. And so keep thinking through it. We've also partnered with other folks, so the AMI group, which is the American Association for Medical Instrumentation. They helped develop the ISO standards and some of those questions that you guys had on the Sputum Bowl last night, those different safety standard organizations. This group largely heads that up. And we've been partnering with them and meeting with them to say, we have big problems in mechanical ventilation. If you ever looked at the alarm parameters of these different ventilators that are going to be in this vendor hall, and see which ones are different, and why are they different? Why do you set a respiratory rate alarm on one of them but not on another? And so these different types of things are something that we have to be proactive about and step up and say, we need to do a better job. And so we've been publishing this type of information in the ARC Times as well. All right, let's move on to quality. I mentioned that to you that healthcare in the U.S. is expensive. In fact, we're the most expensive. And so we're at 17, almost 18% of GDP. And that's not sustainable. You've heard of all the fights on Capitol Hill right now about our healthcare plans not being sustainable, people having to pay higher and higher premiums. And we used to pride ourselves in saying that we were the most expensive, but we were the best. And sadly, as I was mentioning earlier, we're not anymore. We're the 11th best. And so you look at our colleagues in Canada, they're kicking our butt within the same country. You know, it's like it's crazy how, or continent, sorry, that we are actually being outmanned, if you will, outwomaned by another healthcare system that is so close to us that we're not sharing information from that perspective. When it comes to cutting cost, this is where a lot of consultants are coming in and going, let's just cut respiratory therapy in half. Let's get rid of 20%. Because they know that if they get rid of respiratory therapists, they can save on average $1.5 million in most average organizations. It's a significant cut. I don't want to get on the overtime cost, but that's another thing that a lot of times respiratory therapists are living on overtime. They're living way above their means. And when you work overtime, you become dangerous and less safe. And I don't think people get it yet, because they think that having a body there is better than having nobody there, and I don't think that's true, especially when I tell you that 80% of what we do has not been proven to be helpful or effective. Does that make sense? So now you're standing there with a half brain because you've worked 80 hours that week because you want to get that bonus or you want to get that time and a half. I lost a good colleague because he worked a tremendous amount of overtime and crashed his car going home. He couldn't even keep the car between the lines. How in the world did he intubate a patient? Just a prior shift. How did he operate a ventilator and make sure all of his safety checks were done appropriately? Couldn't keep a car between guardrails. And so you know that he was making mistakes. We just didn't catch them a lot of times. And so I'm a big proponent of let's work our hours. Let's be professional and work the hours that we're supposed to, and staff appropriately, those types of things. And that's kind of a directive towards the managers too, is that when you're encouraging this type of behavior, you're actually setting our whole profession up potentially for failure. Because remember, I told you it's about the weakest link a lot of times. And so think through the overtime. It's like, do we really need to do that? And if we don't, then let's not do it. All right, hospitalization for COPD, the numbers. Obviously, it's huge, and it's something that we need to think through. The average length of stay is 4.7 days. There's a significant amount of hospitalization. It's the fourth leading cost of hospitalization is COPD readmissions, and so it's something that we can certainly do better. There's actually studies that show that when we disease manage these patients, they can actually have a lower readmission rate and those types of things. And so when we talk about quality, we have our work cut out for us. Sadly, there's little evidence that says that we do a better job at providing respiratory care than a nurse, for example. If they're given small volume nebs and they're not allowed to practice off of protocols, manipulate or change those types of protocols or orders, then why do you even need a respiratory therapist? I come from a facility where we don't do acute care therapy. We have a consult service. And the reason that director set it up that way many, many years ago is because physicians wouldn't listen to us then. And so he said, if you're not going to value us, peace out. We don't need to be there. You can have the nurses do that. We don't do routine chest PT. So if the physicians want it, we go, hey, you can ask the nurse if she'd like to do it, or the physical therapist if they'd like to do it, but we won't do it. So we've built up a reputation that's saying, hey, we're not doing this stuff. We're not going to just staff up just to provide these therapies that don't make a difference. But we will go out there and we'll consult on every new start, and we'll make sure that we check in with them at appropriate time intervals, but we're not going to be a slave to the small volume nebulizer or the incentive spirometry and those types of things. And that's just because we've had people before us that had the foresight to say, hey, we're not doing that. Sorry. If you want to take us to MedExec and all that other stuff, we'll be happy to go over the literature with them. But it takes guts like that to step up and do that. We need more respiratory researchers. That's my passion. That's what I do full-time as a living, because I want to reduce. If I can reduce that 80% of what we do doesn't make a difference to 79%, I think that'll be a win by the time I retire. But that's how big the job is right now, and so we need more funding for that as well. We need to step up our quality control of our care and take control of that. Often we are told we're reactive. I think that's the way we're trained, is that we want to react to something. So some patient gets injured or hurt, we jump in, save their life. But we're not proactive about preventing that errors in the future or that therapy. Probably the biggest thing that we do preventative is disease management, smoking cessation, if you think about it. But there's so much other stuff that we could do. We could alert physicians about a patient who's not, their trajectory on the ventilator is going in the wrong direction, not wait for them to come around and figure it out for themselves. Be proactive a lot of times, I think, is something that we need to think through. All right, so let's talk about the advanced practice RT real quick. COARC has established standards for that, and so we have not had one facility take us up on that. And I kind of want to use this advanced practice RT to discuss with you how we actually interact with other organizations, what we call the tripartite. And so to be able to change things in the respiratory therapy profession, we have to partner with other organizations. And so COARC is the accreditation organization, and MBRC is the credentialing organization, as you guys know. And so when it comes to developing standards for accreditation, COARC is the ruler. And so we then advise them or give them ideas about what we would like, but they are really in control of that. When it comes to credentialing, the ARC has no, we can't get into their business if that makes any sense. And so obviously the board took action now almost a year and a half ago, I guess, about continuing education. And so we want to push, again, the educational levels up to the bachelor's. So we have a goal of by 2020 to have 80% of respiratory therapists practicing at the baccalaureate level. And so that's our goal. And we're actually doing an interim analysis right now. That survey will come out very, very soon, hopefully by the summer, that we'll actually see how we're going. So we were at 62% the last time we surveyed, and we hope to be somewhere like near 70 or 75 would be great, on our way to 80% by 2020. But we're actively talking about the future. And so the COARC has also established a standard now, 1.01, which now does not allow any new programs that aren't providing at least a bachelor's or higher to be accredited after next year, so January 1 of next year. And so again, we're trying to push them to help us promote the profession and push it further. But we've got our work cut out for us. And so this is a map of just kind of the states of what we have baccalaureate degree programs. And so obviously you're in a great state that has 4. And so it's a wonderful place to be. But you can see there's lots of red there that they don't have one single program and bachelor's entry level program. We also have degree completion programs out there. And so that's, again, mainly geared towards the practicing respiratory therapist. In other words, how do we get them to the next level? And you can see that there's quite a few of those. And so, but again, lots of red on the states or on the map as well that we need to continue. And then we have some that have an abundance. Look at Texas at 6. And I lived in Texas for a little while, and it was easy to hire a bachelor's prepared respiratory therapist with that many programs to think through. When you talk about combining the entry level and degree advancements, there's less red, if that makes any sense. And so because of distance education, I think we're also being able to tear down some of these walls. Even those guys in Montana, for example, or what have you, still have access through distance learning to baccalaureate programs. But we still would love to have at least one in every state, if not many, many more. I recently wrote an editorial with Dr. Bob Kazmarek, again, pushing the bachelor's entry level. And so it's time for us to get to the point where we're going to say it has to happen. We can't keep wishing and hoping that people will do the right thing. We need to start mandating it. And so we're proposing in here a mandate of 2017 or 27 that bachelor's entry level will be the norm. And so again, pushing the profession to plant those trees now, because if we want to get to this goal in 2027, we've got to start now. We don't have enough baccalaureate degree programs to get us to that level. And so we need to keep pushing that, and I encourage you to read that as well. RRT entry level is something that is coming along. Ohio was the first state to adopt, meaning that if you're a new practicing respiratory therapist and you apply for a license there, you have to have the RRT credential. California signed theirs into 2015. Arizona starts in this past year, and that's probably the closest one to you guys, maybe California. I'm geographically challenged. And then there's 6 other states that I think are the geniuses in all this group, is that they've had dual license for many, many years. And so now the hospitals just require you to have an advanced practice license, which means an RRT. And so the entry-level licensure will just basically fade away into the distance. And so they have to do no changes. All it is a requirement by the institution. And then there's about another half a dozen or so moving in the same direction, and we just actually published a guidance document on this to help states with this process. Running short on time, can I have another 5 minutes? Is that okay? All right. A couple things I just want to point out is that RRT is, the majority of states have over 50% of RRT licensed practitioners, and so I think we're winning here. This used to not look like this, but we can't. Some of the states are in like 56 or 60%, so just barely majority, which means there's still a lot of CRTs practicing, and nothing against CRTs. But one of the things that we want to again promote is that we feel like everybody should be working at the highest level, and so when you're educated to an RRT entry level, you should be able to obtain that credential. Otherwise, your educational program is setting you up for failure. And a lot of licensure boards then don't want to allow people to practice at the level that they were educated because they have to worry about the CRTs. Does that make sense? And so you'll always be held back when you have a majority of CRTs there. And so, again, nothing against CRTs and those types of things. It's just more about how do we advance the profession? How do we show the most value for a respiratory therapist? And we think through credentialing is the way to go. Other thing is I mentioned about disease management. This is probably the oldest study that I'll show you is 2010, but probably one of the most influential studies because it was published in the ATS or the Blue Journal, showing that when you have disease management programs in which respiratory therapists participate in, you can actually reduce significantly hospital visits and emergency room visits as well. And so again, we need to keep getting into that arena and not necessarily focus on the 4 walls of the acute care hospital, but actually stepping outside of those. This is the most recent publication, just came out this year, talked about the respiratory therapist disease management programs, and this is one that was actually published through a grant that we provided from the ARC. And they also showed a reduction in readmission, fewer ICU days, and shorter hospitalization due to COPD exacerbation. So getting the respiratory therapist to help disease manage these patients actually improves their outcome and likely quality of life. And so this is big stuff and something that we've been very supportive of. In fact, we actually developed a program now a year ago on the pulmonary disease management course, and we kicked it off in Chicago, and we're now trying to take this online again just to try to provide additional education for the respiratory therapist. When it comes to value, honoring respiratory therapists from outside of our profession is something that we have to do. And so I love it that outside organizations are now picking up on respiratory therapists and honoring them. And so it's one thing to be honored by your fellow colleagues, but it's another thing to be honored by an outside organization. Does that make sense? And so that's when you know that your value is actually embedding all of healthcare. And so it's something that we need to continue to think about. People are also picking out respiratory therapists about success stories. Remember, I keep telling you there's lots of silos of information that I wish that didn't exist. But we found this group that was doing, they had this high weaning success rate. And so we're like, what are you doing? Share with the rest of the world. What are you doing to actually have this success rate? And so they did through that. Wasn't in a scientific journal, but it's something that, again, that we can try to get the word out often. When it comes to value, I think our equation needs to change. And I want to kind of direct this comment to the managers in the room, is that, traditionally we've talked about efficiency of a respiratory therapy department by the number of procedures that your folks do divided by the cost. That's efficiency. And we really need to reevaluate that. I think we need to actually have value equations, and meaning, did you benefit the patient? And so if you can get them out the hospital a day sooner, and that relates to a $7,000 savings, why can't you use that $7,000 to actually show your value? You see what I'm saying? And so you use that, take that money and actually reinvest it in other things. So maybe it's disease management, maybe it's something else. And so looking at benefit divided by cost, not procedures or the number of procedures, because I'm worried that the number of procedures that we do are something that's going to kill us, frankly. I can't tell you, I've had so many employees come to me and say, I was 110% productive. And then when I would ask them, did you actually help someone? It would stump them because they weren't sure if they actually helped someone or not. And so again, think about value from a perspective of benefit divided by cost. And we have to change our practice too. So I'm not pointing the finger at you guys. The Uniform Reporting Manual does not have a value column in it, but it will. Because we have to do that. Same thing with benchmarking. It has to have a value column. So if you're a department that's really, really efficient, but you're doing a bunch of incentive spirometries, are you really helping your patients, or are you just adding to the cost of care? And so over the next 2 years, we'll talk about quality, value, and they're interchangeable a lot of times. And so safety and value, and then, and so these are kind of the next 2 years that we'll go through. I just want to end on showing you kind of how decisions are made. It was awesome to see your House delegates representatives up here talking about this, because this is one thing that I know that I'm pressing them on, is that's the only way that we can get grassroots information back to us, is through those resolutions. And the resolutions have been a little bit low over the last year and a half, 2 years, meaning we're not getting ideas from the grassroots area. And so I just want to focus on the House of Delegates here. So here's the Board of Directors. The Executive Office reports to us. And so the House of Delegates has their own committees, but also the state information. So your representatives, if you want us to hear something, go through them, please. And get them to form resolutions and then bring them to us. And then we meet twice a year and we'll discuss them and hash them out. If it's been approved in the House of Delegates, it comes to us and then we make a decision about. But we also have committees. So we have all types of committees, standing, special, and ad hoc committees. We have special representatives, and so if you're a NeoPeds section member, for example, they have a board position because they have over 1,000 members, and so anybody that has over 1,000 members gets a board seat, and so they can directly come to us. And so we also have a special representative to the American Heart Association, all these different organizations that also provide us reports 3 times a year. So we meet one more time than the House of Delegates from that perspective. But we certainly need grassroots information coming from you guys, because we can't claim to know everything. And it's really not our job. All right, so I talked about being intentional, and with every move we make, I think being intuitive will only get us so far. And so we need to focus on adding value by providing high quality and safe care. One of the things that I was always taught in research is that if it's not intentional, it's not reproducible. And so if you're just out there winging it all the time, you won't be able to reproduce your results. And ask someone who does wing it. You can come ask me later. I wing it often, but I shouldn't. But if you ask them, like, how did you do that to get that patient outcome? And they go, I don't know, turn some knobs. I mean, literally, if they don't have a standardized approach to every time they see a patient, that's the answer you will get when you quiz them on it. And so be intentional and try to do that. And then we need to take calculated risk. I talked about Indianapolis, as a conference being a calculated risk for us, and we want you to do the same thing and let us know. So here's the ask. And so if you're not an AARC member, please join. Please get involved. We do have a place for you. If someone's ever given you that impression that we don't have a place for you, chat with me. I mean, seriously, I think we could find a place for anybody to get involved. Advance your credentials. If you're a CRT, go for a RRT. If you're an RRT that works in adult critical care, get your ACCS. Keep pushing the envelope. Keep pushing yourself a lot of times. Advance your education, same thing. If you're an associate's, get a bachelor's. If you're a bachelor's, get a master's, because that's what you need to be working on. Always be a student, a lot of times. Achieve the best possible outcome for your patient. There's lots of things that we do to patients, but not necessarily for patients. And then serve patients and society well. You speak for us. When you introduce yourself as a respiratory therapist, you speak for all of us. And so if you're doing something inappropriate, if you're not advancing patient care and those types of things, say you're a janitor or something, I don't know, but don't use respiratory therapist. But anyway, a lot of times you introduce yourself that, and people watch you. And you can help us, or you can hurt us just as fast sometimes. And so promote best practices of being part of the solution. It's a team sport. Man, I can't tell you, people say, oh, that's a nursing issue, or that's a physician issue. Get involved. If it affects your patients negatively, get involved. Speak up. Demonstrate that leadership. Behave with compassion, commitment, ethically, honestly, and credibly. And that's something that we continue to have to do all the time. So one of the things I love about Martin Luther King is this comment that he says, and of course I can't see it on my screen. So he's like, if you can't fly, then run. If you can't run, then walk. If you can't work, what does it say? Then crawl. Thank you. And then someone read the last sentence for me. So take a step forward, right? And it's just keep going. Move forward a lot of times. And so a lot of times we can't, we get analysis paralysis, and I tell the board this all the time, is that we want to study the heck out of something before we ever make a decision. But if you know that you can't run, then walk. And so just keep taking steps forward. Never forget that it's about the patient. Be an expert all the time. And then I'll leave you kind of with this, is that something that we really lost Muhammad Ali last year, and he was a marketing genius with his sayings. And this is one that I love because there's no mountain that I can put before you guys that you can't climb if we're all together. But that pebble in the shoe, that person that doesn't want to help us climb that mountain, will stop us every time. And that's what he was saying here, is that, that pebble in the shoe will kill you. And so if you're not going to help us, at least get out of the way. Don't be the pebble in the shoe type concepts. I obviously couldn't do what I do without acknowledging my research lab and colleagues. This is my boss who's actually flipping us off right now. Because that's what he does to me every time I say that I'm leaving. But no, he is a very generous man and allows me to do this. And I have wonderful colleagues that continue to help support me through this. They see this presidency as an honor and something that I also agree with them on. But we're kind of a big family that helps support each other in our professional careers. And then I'll end with that. And I think I have maybe a minute or so for questions. I know I've gone over about 10 minutes or so. This is Harvard Medical School. This is something I walk past every day, and just have a joy of working there. And so, any questions that you guys may have? I know I've kind of dished out a lot, and so I'm going to be around. I'll be around tonight as well. So feel free to come up to me, talk to me. I'll give you my business card, those types of things. I truly do mean what I say, is that if you have an idea or you want to get involved, let me know. I got connections, if that makes any sense. And not like mafia connections, but I got connections. And so I can hook you up with that. And so, any questions? Bored you to tears? Awesome. All right, I'm done.
Why doesn't everybody take a few minutes and stand up, move around, get something to drink, and we'll get set up here. Is that okay? Okay. I'm okay. I think I'll just use the keys from the...
I look at
Okay, if you guys can take a seat, we'll go ahead and get started again.
How are like for timing? Because I know there was a break from 10:30 to 10:45. I mean, I'll get through this.
It's 9:47, but take the time you need and we
Okay.
can. Okay, so our manager breakout session will begin now. If the managers that are interested in going, want to find, you go out this door into the lobby, take a right to room 316. That's where we'll be meeting for that.
No, thanks.
Okay. Okay, so a couple quick reminders. Your yellow form that you have, will you be sure that you fill that out completely, and at the end, there's a little basket on the registration table that you need to put it in. Weaver State students, remember to turn your paperwork in when we're done, and get your tickets, break them in half, and turn them in out in the front too, so that we can use them for the drawing. The first drawing will be after the first break. Okay? So now I want to introduce Dr. Michael Johnson from Primary Children's. He's going to speak to us on improving asthma health through multidisciplinary teams. At Primary Children's Hospital, they reduced admissions for children with acute asthma by timely and appropriate intensive ED treatment. These changes were accomplished with the implementation of a structured clinical pathway that embedded standardized delivery of acute asthma treatments in ED clinical flow and made maximal use of the expertise and input of all our care providers. Mike Johnson and Brandon Anderson helped lead this change. We're going to hear what this change meant to the children they care for and how similar approaches might work in other settings. Dr. Johnson.
Thank you. Okay, let's see. Oh, thanks. Is this microphone picking up out there? Can you hear me with the one that clipped on? Okay, sounds good. Okay, so I purposely pick really, really boring titles for my talks because I think what I'm going to talk about today, I hope, is not just interesting because I'm presenting something that went well or something that we did that we're really proud of, but because hopefully it's something that you can use. The title of this presentation and exactly what we did isn't as important, I think, as whether you can get something from it. I'm going to be talking, of course, a lot about kids because I work at a children's hospital, but the things that we are going to discuss are definitely things that could apply whether you're working with adults, whether you're in an emergency department, an ICU. What I want to get into is the principles of what makes these improvements work that we tried to accomplish. And this is going to build along some of the themes that Dr. Walsh brought up, that we really hope to make the most use of your talents and your professional talents. Just out of curiosity, are there any other physicians in the room? If you're a physician, fess up and raise your hand. Excellent, there are no other doctors in the room. Okay, good, so I can trash on them all I want. All right, so let's get started. So we've got a couple objectives. One, I want to talk about the improvements that we made, and when I talk about multidisciplinary teams, I'm really talking about making the most use of everybody that we have on hand. And I want, as we go through this, for you to get an idea of how you might approach a similar problem in your own realm similarly. Now, half of you are students. You're going to get, this is the best opportunity, I think, for you at this point in your career because you're going to see so many different environments. You're going to do a rotation in an emergency room. You're going to go and be in an ICU. You're going to get a really good picture of how totally different the way that care is provided can be between a hospital and another. And let's give you a little bit of a perspective on what we're like. This is Primary Children's Hospital. This is a view from the street at the emergency department. And we have about 1,000 asthma visits each year. And this is numbers in 2014, because that's kind of where this story starts. We were, that year, admitted about 500 children with asthma. So let me take you back to a little bit. So do you remember 2014? So Ice Bucket Challenge was in 2014. Lots of famous people taking selfies, guys dressed up like Canadian Mounties. This song that all of you are now humming in your heads. And the first time that we ever landed a probe onto a comet, which is a pretty incredible thing to do. Are you still humming Let It Go in your heads? Okay, we're going to move on. So in 2014, how did we treat asthma? Essentially what happened was that a patient would arrive at some point in time in the ER. Our triage nurse evaluates every patient that walks into the ER. They would assess that patient, bring him back to the room. At some time later, a doctor would go in, assess the patient, order a medication, in this case maybe some albuterol. A little bit later, they would reassess the patient's condition. A nurse would go in, see how that neb went, and maybe would involve the RT to come and give a clinical score and give some insight into maybe whether we should treat them better or with more intensive treatment. The doctor would then order maybe a larger volume nebulized treatment, maybe some steroid, maybe magnesium. We're really trying to essentially catch up with this patient's condition. Then at some point later, the physician would decide what condition that patient was in. And most of the time, like you were seeing, if we have 500 admissions, 1,000 visits every year, this is not a math quiz, but that's a 50% admission rate. So most of the time, rather than going home, these patients were being admitted, and we had about a quarter